Thanks, Lisa.
Thank you. All right, so yes, I'm Dr. Lori Dulabon. I'd like to give some clarity on some of the updated prostate cancer screening recommendations, most recently updated by the AUA, or the American Urologic Association, last July 2023. Also talk about some updates in different diagnostic screening strategies and some treatment strategies as well. So again, I have no financial disclosures. I am speaking about a bunch of different companies and products and tests, but I don't own stock in them and don't get any financial kickbacks from recommending one over the other. Some of the learning objectives, I'd like you to become familiar with the incidence, epidemiology, and risk factors for prostate cancer. Acknowledge the most recent guidelines for prostate cancer screening. Again, they were updated in July of 2023 by the AUA. Understand the use of shared decision-making when screening for prostate cancer. That's like the latest and greatest buzzword now in a lot of treatment algorithms, and become familiar with the advances in prostate cancer screening detection techniques, including the use of novel biomarkers, and understand just some of the basic fundamentals of prostate cancer screening, risk stratification, and basic treatment options. So cancer is the second leading cause of death in the United States. Basically, 1 in 4 Americans will die of cancer in their lifetime, unfortunately. It's second behind heart disease. Only in 2022 did COVID-19 beat out accidents as the third leading cause of death. But again, cancer holds this number 2 spot behind heart disease. You can obviously develop cancer anywhere along the urinary tract, from the adrenals all the way down. We're specifically talking about this little walnut-shaped sex organ inferior to the base of the bladder that unfortunately becomes quite a nuisance to men after a certain age. It provides secretions to seminal ejaculate fluid and basically supports fertility function. And again, it becomes a nuisance as y'all get older. So prostate cancer, head and shoulders above any other urologic malignancy, has the highest incidence rate. Nearly 300,000 cases are estimated to be diagnosed in 2024. That's compared to, as we talked about yesterday, testicular cancer. There's about 9,000 cases annually in the United States versus about 2,000 cases of penile cancer and less than 500 cases of adrenal cancer annually. So as you can see, prostate cancer poses a significant problem for men's health. It is the #1 diagnosed cancer in men in the United States. 1 in 8 men on average will be diagnosed with prostate cancer at some point in their life, and 1 in 6 African American men will be diagnosed with prostate cancer in their lifetime. However, luckily, due to our screening and diagnostic treatment strategies, it's the second leading cause of death, but it's a distant second behind lung tumors. So because of our treatment strategies, you can see in 2021, there are an estimated nearly 250,000 cases diagnosed of prostate cancer, but our 5-year relative survival rate approaches 97.5%. This holds true in 2024, nearly 3,000 cases of prostate cancer, and again, nearly 98% 5-year relative survival rates. But just another way of looking at it, again, almost 300,000 cases of prostate cancer last year, with an estimated deaths of 35,000, which is well behind 125,000 deaths from lung cancer, rather. So this is the surveillance epidemiology and end results data. As you can see, when prostate cancer is diagnosed early, localized, oopsies, here we go again, greater than 99% 5-year relative survival rate. Even with regional disease spread, meaning just to maybe the pelvic lymph nodes, still 99% 5-year relative survival rate. It's when the cat gets out of the bag and spreads more distantly, like the patient I presented yesterday and another patient I'll present later in the talk, the 5-year relative survival rates dropped to only 31%. So that's why we're screening these guys. Survival rates are much, much better when we catch it when it's localized. And thankfully, over 80% of the cases, are diagnosed when they're localized due to our advances in screening techniques. And again, it's, the #1 diagnosed cancer in men and the second leading cause of cancer death among men behind lung cancer. Studies have even suggested that prostate cancer is even more common than clinically observed. This was based on Dr. Gabrielle Haas's autopsy studies from a number of years ago. They sliced and diced up prostates in men that donated their bodies to cancer, and even found small foci of prostate cancer in men as young as their 20s. But obviously, one must take note that any screening detection strategy must take care not to overdiagnose prostate cancer or diagnose cancer in a man who would otherwise not suffer from the disease. So what are some of the risk factors for prostate cancer? It's established that metabolic syndrome and obesity are linked to increased risk of prostate cancer. It was actually in the REDUCE trial that obesity has been found to be increased risk for high-grade prostate cancers. Despite this, there's insufficient evidence to recommend specific lifestyle changes or modified diets, but it's kind of intuitive to recommend a healthy BMI to your patients, healthy eating with low ultra processed foods and things like that. But like I said, it's not in the guidelines or anything like that. We know that prostate cancers increase as a man gets older, so age, ethnicity, African American men are at higher risk of high-grade prostate cancers. Patients with a family history, again, 9% of men will have some form of hereditary prostate cancer. These men typically present on average 6 to 7 years earlier than their non-hereditary counterparts, have more aggressive diseases, and in the guidelines, it's recommended to screen them earlier than the non-hereditary counterparts. There's different genes that are associated with prostate cancer. BRCA2 gene is known to be associated with prostate cancer, the HOX2B13 gene, as well as others. Again, these patients typically would present earlier and with potentially more aggressive disease. Hypogonadal men have below average risk for prostate cancer, but conversely, men that are appropriately managed and followed on testosterone replacement therapy do not have increased risks of prostate cancer, despite what one may think. And no food or drug supplements have been approved for prostate cancer. This is based on a few different studies. One was the REDUCE trial that I mentioned earlier, as well as the prostate cancer prevention trial. They looked at the use of 5-alpha reductase inhibitors like finasteride and dutasteride at prostate cancer prevention. In those studies, men were biopsied before they were put on the medicine, biopsied approximately 18 months after being on the 5-alpha reductase inhibitors, and they found actually a decreased risk of low-grade prostate cancers, but a slightly increased risk of high-grade prostate cancers. So it was never FDA approved for chemoprevention for prostate cancer. When we tease out the study and really kind of pick it apart with some of my academic colleagues in urology, I mean, I really truly believe that because 5-alpha reductase inhibitors are known to shrink the prostate over a certain period of time, when those men were rebiopsied at certain intervals, I feel that it was more likely that they found those prostate cancers in a smaller target area rather than actually transforming the cells in just 18 months into high-grade cells. But that's my theory, and as well as others. The other study that supports no food supplements to be recommended for chemoprevention for prostate cancer was the SELECT trial. That was published in JAMA in 2011 by Eric Klein and colleagues. They looked at giving placebo versus vitamin E and placebo versus selenium, just at 400 international units of vitamin E, and I think it was, I believe, 200 micrograms of selenium daily. And that study was actually stopped early because they found a significant increased risk of prostate cancer in the vitamin E group. So this is just the results of the IMPACT study. It just looked at non-BRCA gene carriers, BRCA1 gene carriers, and BRCA2 gene carriers. They did find that the BRCA2 gene carriers had a higher cancer incidence, and they had more likely to have clinically significant disease, which we typically define in the urology world, Gleason 7 or greater. And there was no difference between non-BRCA gene carriers versus BRCA1. So BRCA1 is not associated with prostate cancer. So how do you know if your patient has a HOX B13 mutation or a BRCA2 gene carrier? There's actually genetic cancer testing through this company Invitae. I believe they might have been bought out recently by LabCorp. I'm not sure, but I just sent this test not like a few weeks ago on a gentleman. You can actually order the test. They send a kit to the guy's house. He spits into a cup and they do the genetic testing. They also have plasma tests. You can draw their blood and send the test out. It'll test for all these different genes here, the BRCA genes, B13, as well as others that have an association with prostate cancer. And you get a report in about 3 weeks or so. And they also offer free genetic counseling via like a telemedicine visit for the patients that are positive. So it's amazing, the advances. You don't have to wait 12 months to get in with a geneticist in Pittsburgh or whatever. They have it for all their different disease processes as well. So what about prostate cancer screening? I mentioned yesterday too that while there are typically no signs or symptoms of early stages of prostate cancer early detection, including PSA screening, has definitely played a part in decreasing prostate cancer mortality. Again, I feel, and as well as other urologists, that the PSA and digital rectal exam are a complementary test. I don't feel like you should really do one without the other. I am fortunately diagnosed one of the nicest patients I've ever met in my life in July. His PSA, he's 72, his PSA is 3.2, and he had metastatic prostate cancer, and it was picked up on exam. So it's not a perfect test. We know that. So like I said, the two really go hand in hand, and it's the best screening test, despite all these novel biomarkers I'll get into that we have still to this day. So informed men requesting an early diagnosis should be offered a PSA test and undergo a digital rectal exam. And men that may have a clinical picture suggestive of prostate cancer, please keep it on your radar and think about checking these guys. Like I said, unexplained unintentional weight loss, bone pain, voiding symptoms. It's not always due to just benign prostate hyperplasia or BPH. It could be due to prostate cancer. So PSA, as you know, stands for prostate-specific antigen. It is not a perfect test. It was FDA approved in 1986, but again, it's not perfect. There's a lot of false positives and negatives with it. As you know, men with BPH, other benign conditions, urinary retention, prostatitis, urinary tract infections can falsely elevate the PSA. And men, as I just mentioned, my patient from the summer, he had a normal PSA, what's considered normal, Quest and ACL report, anything less than 4, 4 is normal. And just to mention, we'll talk about age specific ranges for prostate cancer. A man who's 51 years old should not have a PSA of 3.9. That's too high for his age range, so I use those a lot in my practice, even though Quest says it's normal, it's not. And obviously detecting tumors doesn't always mean saving lives. PSA may be positive in a guy that has a very slowly growing, otherwise indolent tumor that may otherwise never affect his or threaten his life. So obviously there's false positives, false negatives. So I kind of always joke that PSA should stand for persistent source of anxiety rather than PSA. So again, PSA screening has definitely played a part in decreasing prostate cancer mortality. This slide is very demonstrative of this, of that fact. As you can see, what happened in 1986, PSA was FDA approved. So it was widely adopted early on by urologists as a screening technique. And you can see back in the 70s and 80s, 5-year relative survival for prostate cancer was around 65, 70%. PSA invented, now we're up to that 97, 98%. So you can't argue with that. However, I talk about this fairly frequently. In May of 2012, the United States Preventative Services Task Force made recommendations concerning clinical preventative services and issued a Class D recommendation regarding the use of serum PSA in prostate cancer screening. They felt that PSA screening and otherwise, healthy men was ineffective and that the harms outweighed the benefits. And they recommended that it would potentially cause more harm in the form of treatment morbidity than benefit. And I think this did a huge disservice to patients and family practitioners alike. This was widely accepted as gospel in the medical community, not by us urologists per se. I never changed my screening parameters for patients, but even a draft of this article was leaked, to the media in October of 2011, prior to it actually being officially published. And like I said, this was just disseminated out. And so then abruptly, a lot of prostate cancer screening just halted, and it did a lot of damage, in my opinion. I'll show some data to support that. It's important to note too, on this task force, there wasn't a single board certified urologist sitting on it. It was a federally appointed group of 16 individuals, none of whom were urologists. So not sure why they did that, but again, this came out in May of 2012, was widely like disseminated to the media in October of 2011. So to combat, to use a common term now, the disinformation or misinformation, in the New England Journal of Medicine, the European randomized study for screening for prostate cancer and their 11-year follow-up data was published. It was the largest and longest independent trial of prostate cancer screening in men at European centers. It included over 180,000 men, and they randomized guys to screening or not screening for prostate cancer. And they found at a median of 11 years, the relative reduction risk of the death of prostate cancer in the screening group was 21% and 29% for adjustment after noncompliance, which means 5 cancers need to be detected over the lifetime of screened subjects to prevent 1 death from prostate cancer. So it does make a difference. This was their, study protocol. Basically, if a man had a PSA of greater than 3, it triggered them into the biopsy arm. And like I said, they found, and they also extended this data later out. They found that, the bulk of men that benefit from prostate cancer screening is between that 55 and 69-year mark. Those are the men that benefit most. But like I said, it does decrease prostate cancer mortality in screened individuals. Also, the Journal of Clinical Oncology, they reported from Memorial Sloan Kettering their rebuttal response to the U.S. Preventative Services Task Force data, and they just kind of had some no-nonsense recommendations, which I agree with. Avoid PSA testing in men with little to no gain. I mean, if they're rolling into your, exam room in a wheelchair with oxygen, and they have a estimated ejection fraction of 9% and all, and they're not going to live another 10 years, don't be checking PSAs on them. There's little to no gain, benefit in those patients. And do not treat those who do not need treatment. There's a lot of new algorithms for patients on active surveillance and things like that. They have to be closely monitored. It's not watchful waiting. We are actively doing things periodically to make sure nothing's changing or progressing. And then because it was Memorial Sloan Kettering, I think they wanted the business. They also recommended to consider referring men who do need treatment to high volume centers. But obviously not everybody can travel to Memorial Sloan Kettering to have their prostatectomy. So this was a fantastic paper. It was a multi-institutional paper published by various radiation oncology departments nationwide by Butler et al. It was published in 2020, and it looked at the prostate cancer incidence across the stages before and after the United States grade D recommendations. And they demonstrated a reverse migration in prostate cancer away from more indolent disease towards more aggressive disease beginning in 2012. What happened in 2012, what was widely disseminated in the media in October of 2011 prior to that, like I said, it just immediately halted prostate cancer screening. The incidence of localized disease then declined also across all age groups from 2012 to 2015, and the incidence of distant metastatic disease increased throughout the study period. So the AUA has always recommended to screen for prostate cancer. They most recently updated the guidelines. They changed ever so slightly in July of 2023. They recommend for earlier screening, but a little more looser in patients that don't have as stronger risk factors. So they recommend that clinicians may begin screening and offer baseline PSA testing between 45 and 50 years of age. They should offer regular prostate cancer screening, which again includes PSA and digital rectal exams, approximately every 2 to 4 years for people age 50 to 69. Those are for the low risk patients. Again, I find that hard in my practice to do something every 4 years. I mean, we can only schedule out for 2 years at a time, so I can't have patients coming back every 4 years. But they're in your office and that you're seeing them every 6 months for their A1Cs and different things like that. Just keep it on your radar to check them at least every other year if they're relatively low risk. Again, you can personalize the screening interval and decide when to discontinue screening based on the patient's preference, their age, their previous PSA history trend, prostate cancer risk factors, life expectancy, and general health. So PSA screening, however, should begin even earlier for men at higher risk. This includes those African-American men, men with the germline mutations, and family history. They recommend getting a baseline PSA at 40 to 45. So any male I diagnose with prostate cancer, I always ask them if they have adult male sons and always mention to them at 40, they should get their first PSA and rectal exam. If it's normal, then consider getting another one by 45. If that's normal, and then every year thereafter, in my opinion, from 50 to 70 to try to capture and catch him early if he develops it. So patients with a newly elevated PSA, it's recommended that instead of just automatically biopsying them or things like that, because there are a lot of false positives, false elevations with PSA, to repeat the PSA prior to any other further interventions, including secondary biomarker testing, biopsy, or imaging. And again, these buzzwords now is the AUA recommends shared decision-making for men. Again, it's bilateral, like sharing of information. It's just basically counseling your patients and also taking into the account some of their potential socioeconomic factors that may affect their or biases. Some guys have said, every male in their family has had prostate cancer. They had their prostate out. He wants his prostate out. They do, so every patient has their own inherent, like I said, biases and with prostate cancer screening and treatments. So again, unfortunately, the United States Preventative Task Force, they recommend it in their guidelines, but it's also embedded in the AUA guidelines as well. With that shared decision making. It's a strategy for making healthcare decisions when there's more than one medically reasonable option. Like I often, counsel my patients and put a line in the chart saying, prostate cancer screening risk factors were discussed with the patient. He agrees to proceed, something like that. So it's documented. In spite of these recommendations, shared decision making is not frequently used. But just to help facilitate it, there are free patient aids through the Urology Care Foundation. You can order, put them in your office, to help facilitate discussion for men. You can document them that you gave him this little trifold, pamphlet, is prostate cancer right for me? There's also online screening tools. You can say they answer these questions and they agree to proceed to prostate cancer screening, just as a suggestion, perhaps, to make it easier. So PSA, again, it's not a perfect test. So there's, some refinements. I utilize on a daily basis in my practice. It's basically called PSA kinetics. It looks at, potentially PSA density or the relationship of the level of PSA to the size of the prostate. A PSA density of greater or equal to 0.15 suggests the presence of prostate cancer. So for example, a guy with a PSA of 5 and a prostate gland size of 50, his PSA density is 0.1, which statistically, he would be less likely to have prostate cancer if he were to have a biopsy. PSA velocity is the change of PSA over time. I use that all the time. I don't look at one isolated value. I kind of look at the trend over time. PSA velocity, it has to be determined by 3 different measurements, at least 6 months apart, too. That's the definition of that. So PSA velocity of 0.35 and a man with a PSA value of less than 4 has a higher relative risk of dying for prostate cancer, and a PSA velocity of 0.75 nanograms per milliliter per year for patients with a PSA of greater than 4 have a higher incidence of having prostate cancer mortality. So again, this is something else I use quite frequently too, the age-adjusted PSAs. Again, even though Quest and ACL report less than 4 is normal, it's not normal. 4 is not normal in a 40-year-old guy. It should be less than 1.5 in general. A man in his 50s, it should be about 3.5 or less. A man in his 60s, we can actually allow, because as a man gets older, typically his prostate enlarges. The larger the prostate is, the more of that prostatic specific enzyme he emits into the bloodstream. And men in their 70s normal can be, in the 5 to almost 6 range. We also sometimes look at the free to total PSA ratio. A number less than 20 is suggestive of possible prostate cancer, but I don't think I've ever biopsied a guy exclusively alone based on a low free PSA personally. It's usually other factors that weigh into it as well. So as I've alluded to, PSA testing is flawed. The positive predictive value is only anywhere between 25 and 40%. Risk assessment is flawed. That's why now we have a lot of these new novel biomarkers that have emerged as ancillary tools to help us guide clinical decision-making in various clinical scenarios. So again, just a little about prostate-specific antigen. It's an androgen-regulated kallikrein serine protease produced by both prostate epithelial cells and prostate cancer. It's a major protein in semen and functions to liquefy semen for fertility purposes. PSA then can enter the circulation intact and is rapidly bound by protease inhibitors, primarily alpha-1 anti-chymotrypsin. And it's this proteolytic inactivation, as well as the cleavage of pro-PSA to PSA, that is less efficient in prostate cancer. And it's a lot of these biochemical features of PSA that are the hallmark of a lot of our new biomarker tests. So here, let's see how well you've been paying attention. So we got a 62-year-old gentleman. He comes to you. He has a PSA of 4.6. It's the first PSA that's ever been checked. He's otherwise healthy, active, sexually active, and he has no symptoms consistent with UTI or lower urinary tract symptoms, and he has no known family history of prostate cancer. What would you do? Oh, his exam's normal too. So good, you examine him first. And then the patient says, doc, my friend says biopsies are painful. I heard that treatment's a bad idea. Can we skip it? So what would you do in this situation? Yes. Excellent. You get an A+. You are correct. So yes, repeat the PSA. So that's in the guidelines. There is also a study that showed that about a third of guys, when their PSA is repeated, their PSA will normalize. So he comes back to you with the repeat PSA 4 months later. There's some certain things, like I do have some avid road bikers in my practice and things like that. The half-life of PSA is about 3.5 days. So if it is falsely elevated for some reason, it takes 2.5 to 3 weeks to normalize. So don't check it again like right away. So he's asked to refrain from sexual activity, riding a bike for a couple weeks prior to the test to minimize any false elevations. However, his PSA is now 4.8. And the patient asks, doc, are there any other tests we can get? He's really trying to get out of this biopsy. So additional testing is, the goal of these tests are to try to identify men who can potentially safely avoid biopsy. Again, this man has a normal rectal exam. Of note, if he had an abnormal rectal exam, I'd be getting him in for a biopsy. And biomarkers as well as MRI are being utilized more frequently in this space to help identify patients who can, like I said, safely avoid prostate biopsy. So some of the novel biomarker tests for prostate cancer, there's a lot of them. We're going to talk about the ones I highlight in red here. The ones with the asterisks are urine studies. Other tests, this Affinity, ProMark, those are actually tests you do on the tissue that are obtained during a biopsy, and some of them are serum blood tests. So prostate cancer, or PCA3, is a specific non-coding RNA. It was first identified in 1999. It is FDA approved and on the NCCN guidelines for early prostate cancer detection. Its expression is restricted to the prostate, and it's found to be highly overexpressed in prostate cancer cells. The nice thing about it, it is independent of prostate volume, age, BPH, and prostatitis. They don't take other clinical factors into it. They just give you a number score, but it has to be done in the office because it does require a DRE and a post-void digital rectal exam urine test. Studies have shown that a PCA3 correlates with the risk of prostate cancer. A low value, meaning less than 25, is considered negative, whereas a high value equals a higher risk of aggressive prostate cancer. So intuitively, patients with a low PCA3 score could potentially be spared a biopsy. There's also the Prostate Health Index. This is actually a mathematical formula. One of my colleagues at NYU came up with this one. They're kind of nerdy, not gonna lie. But they looked at the probability of detecting prostate cancer by combining 3 different blood tests. So again, this is a blood test. It looks at the total, free, and pro-PSA. It's FDA approved and also in the NCCN guidelines. It has shown that it reduces unnecessary prostate biopsies by 30%. Again, a prostate health index score was significantly higher in men with greater than or equal 7 Gleason 6 prostate cancer. Their cutoff is 28.6. This is the mathematical formula here. And again, a cutoff of 28.6. Men can avoid 30% of biopsies with benign or what would be deemed insignificant disease. The next one is the MIPS score, which used to stand for the Michigan Prostate Score because it was developed at the University of Michigan in Ann Arbor. Now I believe they rebranded it as My Prostate Score. It combines also a panel of biomarkers, the transmembrane protein series, PCA3 and PSA. This also requires a post-DRE, so this has to be done in the office setting. It was found on multivariate analysis that the combination of the PCP TRC plus PCA3 are slightly superior to just PSA alone and everything like that. Their area under the curve is, 0.8 is good, so it's 0.75, which is superior to just PSA alone, obviously. There's also the 4K score. This is a proprietary for kallikrein panel. It includes total PSA, free PSA, intact PSA, and human kallikrein related peptidase. It does combine other additional clinical information in their algorithm to come up with the score. It is also FDA approved and has a 95% negative predictive value. This also has been shown to correlate with cancer risk and aggressiveness. So patients with a high 4K score should be biopsied. Again, this one takes into account, what the DRE findings are. But again, if a man has an abnormal DRE, he should be going for a biopsy. So the DRE, in my opinion, should always be normal if you're sending this test. Takes into account the age, prior biopsy status into their treatment algorithm to give you the score. Select MDX is a gene panel, also post first catch urine in after a vigorous DRE. So again, done in the office setting. It also combines age, PSA density, family history, digital rectal exam findings, and prostate biopsy history into its algorithm before it gives you a score. It looks at the HOX6 gene, the kallikrein panel, and DLX1. It has been shown to have a great area under the curve of 0.9%, which equals a 95% confidence interval that a low select MDX score could reduce the number of unnecessary prostate biopsies. This is what a report looks like. I used to use a lot of this, like in Georgia when it first came out, because I took over, my partner left, and I noticed I had all of his patients, and then I needed to see these patients that had 3, 4 prior negative biopsies, and their PSA was still elevated, but I really didn't want to biopsy him a 4th or 5th time. So this had recently come out. I started, sending in, and I get reports saying very low risk of clinically significant prostate cancer. And it gave us reassurance that the guy didn't need another prostate biopsy. But I don't know what happened. A few years later, I was never getting very low risk. I was getting like 50-50 wishy-washy answers, and it wasn't helping me clinically in my practice to send this test. So then I actually started using this ExoDX, because you can't use them all. You got to kind of pick one and try it out for a while. If you're getting good clinical information that correlates with what you find in clinical practice, then it's useful. If not, then I stopped using it. But ExoDX, this looks at different secretions from tumor cells, including mRNA and RNA and proteins in the urine. It does not require a vigorous digital rectal exam and giving a sample. So you can actually, again, send a kit to the patient's house and they can do it at home, which is good for some of my rural patients or some of my guys that can never urinate in my office, even though I always tell them to come with a full bladder for various reasons. Oh yeah, I just went in the waiting room. I'm like, So you can actually, they get the kit within a couple days. As long as they do it, you get a turnaround time within a couple weeks and get a report. I like it because, again, non-DRE urine, so they can do it at home. Good negative predictive values. It's included in the NCCN guidelines, and you get a number, and it doesn't take into account any other clinical factors. You don't tell them, anything else. They'll know the patient's age. That's about it, that they're a male, and they'll have a urine sample on them, but it doesn't take into account their PSA, their family history, anything else. It just gives you a number between 0 and 100. Their cutoff they use was 15.6. I've been doing this long enough now that I do find that 20 to 30 is a little bit of a gray zone. I mean, in the beginning I was biopsying everybody that was definitely above 20, and 20 to 30, like I said, they're not always positive. Like the higher it is to 100, the more likely they have aggressive prostate cancer. So there's a good correlation there, but again, nothing's perfect. So once you do these tests, once you decide that a guy needs a prostate biopsy, you need to go ahead and get the tissue diagnosis. So the good old-fashioned way, and the best way that we still do most prostate biopsies, are performed via a TRUS, transrectal ultrasound, needle guided biopsy of the prostate, typically done in the office setting under a local, periprostatic nerve block. Most guys tolerate it very, very well. They come in with a full bladder. I give them an antibiotic to start a couple days prior, continuing them on it for 5 days. They have to void after the test, and we get at standard template is to do 6 cores from the left, 6 cores from the right. Sometimes if a guy's prostate's extremely large, I'll do a couple extra cores if he's tolerating it. Or if one of these biomarker tests I'll talk about in the future is positive in a certain area, I might sample that area a little further with additional biopsies. Obviously, I always offer a guy if he wants like MAC light anesthesia in the operating room, he can always have that as well. So you can also do a transperineal prostate biopsy. Done a few of these in guys that have had multiple negative transrectal ultrasounds. It does require general anesthesia. You use this grid-like fashion that goes and you transverse through the perineum to biopsy the prostate, and you biopsy the dickens out of it. You get 25, 30 cores. If you can't find prostate cancer on that, then quit looking for it, in my opinion. So this just shows the angle of the needle and the different biopsies. Obviously, transrectal is a little bit more of an acute angle, where transperineal goes directly into the prostate. So obviously lower risk of infection with transperineal because you're not going through the rectum, but it does require anesthesia. So there's risks and benefits to everything. MRI is being utilized more frequently. It does MRI fusion biopsy. It's basically where you get an MRI and they inlay that with real-time ultrasound. So it still doesn't take out, you're still doing the truss ultrasound, but it's very expensive, like almost $200,000 software that the hospital has to buy. So that way you can target these lesions, these PI-RADS lesions, just like breast mammography, they report BI-RADS lesions, anything greater than 3 is reported as clinically significant. MRI, and again, it's only as good as the reading radiologist to tell us where these lesions are, to target the biopsies to try to find these higher grade clinically significant prostate cancers. I also use, and again, a negative MRI does not exclude the possibility of cancer, and you can also have, potentially negative MRI fusion biopsies as well. Also known as UroNav. There's some, companies that support this technology. Again, some different high-RADS lesions within the prostate, so then you target your biopsies to that area. So once you do the tissue diagnosis, you send it to your local, friendly pathologist or ProPath, and you get typically a Gleason score adenocarcinoma. 99% of prostate cancers are adenos. You do have the rare, signet cell tumors, neuroendocrine tumors, some of those ductal adenocarcinomas, and some things that are more rare. But like I said, 99% are adenos. The Gleason score, as I'm sure you're familiar with, was developed by Dr. Donald Gleason in the 1960s, but it wasn't widely adopted until the late 80s when PSA was FDA approved to try to standardize prostate cancer reading under the microscope amongst pathologists. So basically, pathologist looks at the tissue under the slide, reports 2 scores, anywhere from 3 to a 5. 5 is the most aggressive. The most predominant cell type is always reported first. So a Gleason 3+4 has a better prognosis than a Gleason 4+6. They both equal 7, but because a Gleason 4+3 has a more predominant Gleason 4 cell pattern, it is more aggressive disease and needs to be treated accordingly. So this is clinical prostate cancer screening. If a guy undergoes a radical prostatectomy, that's called surgical staging. It's slightly different, but essentially the same. Basically, T1 disease is prostate cancer that happens to be picked up due to an elevated PSA. It's also prostate cancer that may be incidentally detected on TUR, transurethral resection of the prostate, depending on the volume of tissue, positive for prostate cancer. Whereas T2B disease, stage 2, is disease that's palpable, either in one lobe or 2. T3 disease is prostate cancer that's starting to grow into adjacent organs like the seminal vesicles. MRI after a guy's diagnosed with prostate cancer is very useful to demonstrate seminal vesicle invasion. If he has some features either on genomic studies and things like that that he may have more aggressive disease, getting an MRI preoperatively or even prior to radiation therapy can be useful to be able to treat him most effectively. And T4 disease is cancer that is spread into the bladder or pelvis. So I talked about the National Comprehensive Cancer Network guidelines. Again, it's a free resource for physicians. They also have a really nice patient portal. I send my patients to It's free. It's sign up for it. It updates frequently. Like prostate cancer screening has been updated just most recently this month. It's now up to a 223-page document, so it's very robust, but it contains all the latest and greatest information. I provided the link here specifically, so you can just click on that for prostate cancer, but every other most common cancers they have guidelines for out there. So these are the guidelines here. So any man with intermediate unfavorable prostate cancer, that's PSA between 10 and 20. He has the Gleason 4+3s. He warrants soft tissue imaging and bone imaging. So old school, we were doing CT scans, actually not that long ago, and CT scans of the abdomen and pelvis with contrast and nuclear medicine bone scans. In 2016, there was a PET scan called Axemin that was approved, but it wasn't approved for early diagnosis. It was just approved for men that have evidence of possible biochemical disease recurrence after definitive treatment. And most recently in 2020, we have the prostate-specific membrane antigen radiotracer, also known as the PET PSMA scan. And this has been a game changer in the prostate cancer world. It's highly expressed in prostate cancer cells. You can see these micromets here. These are like 4 mm areas of metastasis that would easily be missed on regular CT scan. So the NCCN recommends PET PSMA scanning as an alternative for bone and CT scan imaging for initial stratification for localized prostate cancer, newly diagnosed unfavorable intermediate. Unfortunately, the lower risk guys, they don't get this approved by their insurance because they're not, it's not on the guidelines to do it for like the Gleason 6s. But it's also applicable for detection of biochemical recurrence. And men after definitive therapy, if their PSA starts creeping up, you can order the PET PSMA scan and look for any metastatic disease. Men with castrate-resistant prostate cancer, shown to be M0 on standard workup imaging to look for other areas of potential metastasis and workup for progression. So this is a slide of that old, it's not even old, 2016, it's not that long ago, but this is the Axemin scan, the 18-flucyclovine PET scan. Here is it compared to the PET scan. Here you can see these lymph nodes light up like a Christmas tree here, and these would otherwise be missed on the Axemin scan. Here's just a regular, this is a different patient here. You don't really see anything here, but on the PET PSMA scan, you see this positive presacral node here, easily missed. So it's amazing. Unfortunate that I'm diagnosing more metastatic prostate cancers, but at least then we can get the guys treated in a more timely fashion. So again, here's the NCCN guidelines. Here for patients with low risk, very low risk, and I don't use active surveillance for favorable intermediate, but they say you can potentially use active surveillance for favorable intermediate. I only use active surveillance for Gleason 6s myself. And again, it's actively surveilling them. Typically, they undergo a repeat biopsy within a year. Then if that is unchanged, then usually at the 2-year mark, I'll get an MRI, make sure there's no change. They're getting PSAs every 6 months, rectal exams every 6 months, make sure nothing's changing. And because they don't want to potentially undergo any of the potential side effects of prostate cancer, incontinence, impotence, etc. So some of these, and also my patients have to have a favorable molecular genomic test to be on active surveillance. For me, there's several of these. It looks at the tissue that I've already taken from the prostate biopsy specimen and looks at it in a molecular way. So Oncotype DX is a genomic assay. They report a GPS score ranging from 0 to 100. I like my numbers. That corresponds with the biological aggressiveness of the tumor. It looks at 12 different genes expressed in prostate cancer and tries to predict the likelihood of adverse pathology, prostate cancer death at 10 years, metastasis at 10 years, and biochemical recurrence at 3 years. Again, here's a patient with a GPS score of 35. Again, I probably wouldn't recommend active surveillance for him because he's creeping into the intermediate risk category. I like a low or very low score to keep a guy on active surveillance. I would encourage him, depending on his age and other risk factors, to consider definitive treatment. Confirm MDX, conversely, is a tissue test that looks at DNA methylation. This is for the guys that actually have a negative prostate biopsy, and at their 6-month follow-up, maybe their PSA keeps creeping up, even though their exam hasn't changed or anything else. You can actually take their tissue. It's good for up to 18 months and send it for confirm MDX. It looks at DNA methylation that is associated with the potential risk of prostate cancer. Because yeah, could I have missed it? Obviously, absolutely. I mean, especially when I'm biopsying, sometimes these guys have 90-gram glands. Taking 12 cores, you take 12 cores from a guy with a 15-gram gland, like your sample, like I said, for guys with big prostate, sometimes I'll take a couple extra just to sample it a little better. But yeah, I mean, you can definitely miss it. It does have a 96% negative predictive value for high-grade cancer. It's included in the NCCN guidelines. So it may help prevent unnecessary repeat biopsies in guys if they have a negative confirmed MDX. Like I said, this guy here had a positive DNA methylation in this core here. So at repeat, if his PSA keeps trending upwards, you might consider MRI to look for a PIRADS lesion in this area for MRI fusion biopsy. You might just, take him back for a regular truss and take some extra cores from this area here. So again, we talked about active surveillance. You're actively doing things. Like I said, it's not just watchful waiting. These guys are actively surveyed frequently, and I do insist on a repeat biopsy at some point, usually within a year, but some guys will wait, 18 months to repeat biopsy. And I've taken guys off, like my younger guys, if they elect for active surveillance in their 50s, I tell them that eventually we're going to be doing something. You're just kind of staving off, potential impotence and possible incontinence associated with definitive prostate cancer treatment. But yeah, any guy that was in his 50s at some point, he comes off usually within a few years, because the repeat biopsy shows a Gleason 7 now, and he's okay with it, and they get their definitive treatment and they're doing fine. So also radical prostatectomy in general. My guys under 60, I recommend for prostatectomy in general. I mean, obviously every patient's an individual. Everybody has their individual biases and things like that. Radiation for my guys in general between 60 and 70, I think they have the option, as long as they're in relatively good health, to either have a prostatectomy or undergo definitive radiation therapy. Not too many studies have shown a huge statistically significant difference between definitive surgery versus definitive radiation. They have equal cure rates. However, in higher risk prostate cancer, bimodal radiation therapy has proven to be superior for mortality outcomes. For radiation, you have the external beam radiation and brachyseed implants. Again, those socioeconomic factors, that aren't in the guidelines. Some guys live remotely and they're 76 years old. They're not good surgical candidates. They can't be driving in for 40 external beam radiation treatments in the snowy roads here. They're on a fixed income. They can't afford the gas. So in the right patient, brachyseed for monotherapy, where they come in one and done, we implant the seeds, and an hour and a half later they go home. They're great candidates, and then you don't have to worry about them getting lost to follow up and things like that. So keep that in mind for your patients as well. So just to finish up, I think I'm way over time or something. I'm sorry. Just a patient example. Hopefully I don't get overclumped here, but 54-year-old Caucasian gentleman referred to me for worsening LUTS. His IPS score was very elevated at 26 with a bother of 5. Upon further questioning, he noted that he had severe back pain for 6 months, but his occupation was laying floor. He did hardwood flooring, was always on his knees and hands. And so he chalked it up to that. He'd been going to a chiropractor, going to his primary care doctor, getting different x-rays and things like that. And he also admitted to a 15-pound unintentional weight loss. On exam at his initial visit with me, it was extremely abnormal. It was like this table here, and it was very uncomfortable for him. So I knew exactly what was going on. I also noted that he had a recent CT scan without contrast performed at our institution 2 months prior. And to me, it looked like he had evidence of osteoblastic disease and a significantly thick-walled bladder. So to me, this is not normal here. That is not normal there. That is not normal there. And here's his little bladder, super thick-walled and not normal. However, our radiologist said no acute pathology was present. So in the primary care defense, they were trying to find a source for they sent the guy for a lumbar MRI, and it was reported all he had was a generalized degenerative disc disease, nothing to see here, doesn't report any lymphadenopathy, nothing like that. So anyway, I was very worried about this guy. He was very young, full of life, and checked a PSA that same day. I don't usually do that. I say, oh, come back in a few weeks, check it and come back. But I ordered and checked it that same day, and it came back 2,211, which is still the highest I've ever seen. He underwent prostate biopsy with me under MAC anesthesia a week later, because there was no way he would tolerate it in the office. Like, just the exam alone was super uncomfortable for him. And here you can see on all the dark purple spots are prostate cancer there. So very high volume disease, back-to-back glandular infiltration here. You have perineural invasion here. Here you see cancer cells just wrapped around these nerve bundles. Higher power magnification of that. So every core was positive for Gleason 8 and one core was positive for Gleason 9 disease, and perineural invasion was found in every core in this patient. He was immediately approved for Casodex. I was worried about his CT scan. He was going to like a chiropractor for his back pain. I said, please stop that. And he was immediately set up with oncology. It was unfortunately at an outside institution because we don't have medical oncology at our institution, and his metastatic workup was positive for widespread diffuse osseous metastatic disease. He had multiple compression fractures, T3, T4, T10, cord compromise, foraminal stenosis at C3 and 4, T3 and 4, and T10 and 11. And unfortunately, I don't know if after he had spinal radiation therapy, he initiated androgen deprivation therapy and chemotherapy. If he had some swelling with all of his osteoblastic disease, he suffered neurologic compromise and he's a paraplegic now. He's still alive, but he's suffering a lot of the consequences that are known to paraplegics. And yeah, so he's 57 and in a wheelchair and has, decubitus ulcers and neurogenic bowel and bladder and all these other things. So please, when a patient has clinical signs and symptoms of prostate cancer, please keep it on your radar and check these guys. Digital rectal exams free. You can check a PSA on him, and the new guidelines recommend starting to screen by 50 in the 45, 50 years of age. So hopefully guys like this will be caught sooner in the future. So while there's no signs and symptoms typically of early stages of prostate cancer, it has played a part in decreasing prostate cancer mortality, prostate cancer screening, that is. Informed men should be given a PSA test and undergo a DRE. Men that have a clinical picture should undergo testing. Use shared decision-making in your practice. And like I said, PSA testing does have lack of specificity associated with it. So that's why a lot of these more novel urine and serum biomarkers offer additional information for our patients to try to improve biopsy decision-making and prostate cancer detection. Any questions? Yes, sir. Not yet, in my estimation, it should not replace it, but too old. I mean, I asked longevity. How old do the patient's parents live? Like sometimes my patients say, my mom lived to 101, my dad was 99. It's not unreasonable if the patient wants it to continue to screen them. If they say, I don't want to die from prostate cancer. I had 2 buddies that died from metastatic prostate cancer. I never want to go through that. It's not unreasonable. So I do have guys in their 80s that come to me for prostate cancer screening, based on that. So based on their longevity, their health status, if they're still, walking 3 to 5 miles a day, they eat healthy, they look great, they look better than 60-year-old counterparts. There's nothing wrong with that. Like I said, these are guidelines. It's not cookbook medicine. So I use it individually like that. Yes, sir.
Seem to get a lot of calls. Patients that PSA wasn't covered. Do you have any thoughts on like the best way? And typical 50-year-old comes in,
Yeah.
say screening test order, calls not covered.
That's
If we use nocturia, it is.
Z1 12.5 is prostate cancer screening.
Right.
Yeah, I mean, it should be covered. In my opinion, I do have some Medicare patients where they have to sign a, release that they might not be covered. Because, a lot of the guys that I see, I'm checking it more than once a year, so often every 6 months or so. What do they call it? Something of benefits. You know what I mean? They have to attest that they might get a $150 bill for it. But yeah, I mean, I don't know what kind of insurance they have, but yeah, I don't see that. And, yeah.
Screening. Usually go back. So you have to have some sort of symptom or something.
Things say BPH, with or without obstruction, family there's a code for family history of prostate cancer, if they have a family history, things like that, maybe or get arounds for that. Yeah. Mhm. Mhm. Yeah, they're covered for Medicare patients. For commercial insurance, there is a risk of potentially like a $900 out-of-pocket cost. I've never had a patient have to pay that. Honestly, I do counsel them that it could be a couple $100s. They have different financial pathways. They have lots of study, and there's so much money going into prostate cancer research because how many very wealthy men, honestly, every year are diagnosed with prostate cancer. So they donate a lot of money to prostate cancer research causes. So there's funding for it. But I do tell them like there's a possibility with commercial insurance and you're under a certain age that you might have to pay $200 out of pocket. For a guy to potentially not have to have a prostate biopsy and for his health, most of them say, yeah, let's do it. But like I said, I don't, but they have, like I said, it's called EXO for specifically EXODX. They have an EXO Cares program where it's a financial pathway. If you get really far down the road, it does get invasive where you have to submit your W-2s and things like that. So you have to declare your financial income, just like trying to get, certain medications and things like that to try to get it completely covered. But most of the time it's covered or a nominal cost, a few $100s. But there is a risk, like when they sign, that it could be as much as like $900. But I've never had a patient have to pay that. It says it in their explanation of benefits and they freak out. But ultimately, like I said, at most, it's usually around $200 out of pocket. Mm-hmm. Yes. Mm-hmm. No, it's still a treatment option, usually for biochemical recurrence in a patient that's had prior radiation therapy. Not so much as a monotherapy modality. There are, potential side effects to it, risking, rectal damage and things like that from the low temperatures. But yeah, and it kind of picked up again because they were doing these focal ablative therapies. They still are something called HIFUs and cryotherapies when they can isolate a PI-RADS lesion within the prostate. It looks like a focal solitary lesion, and they can target that with HIFU cryotherapies, things like that. But I'm of the schooling that prostate cancer is typically a multifocal disease, and I don't believe in focal therapies, honestly, for prostate cancer, myself and for my patients. But whole gland cryotherapy for biochemical recurrence after radiation therapy, it's still being done and an option. Yes. Oh, well, I already addressed that one. So how much does the cost of genetic testing? And I do routine PSA related to someone's level below 1. I mean, as I said, I really feel that the digital rectal exam, yeah, I mean, if you can't feel their prostate due to a patient's, body habitus, you just document it and you try it. I always have my patients like bear down, like they're having a bowel movement that helps move the prostate down closer, to my finger. But yeah, some guys have very hypertrophy gluteus muscles and my little hand can't get in there. And I just document that I can't feel it, but I always at least try. Because yeah, I'm a big advocate because I do pick up prostate cancer. About 15% of men will have a normal PSA despite, having prostate cancer detected. So you'd be missing 15% in theory based on statistics if you're not doing the rectal exam and then risking them being diagnosed at later stages and things like that. So, but yes, sometimes it is difficult. I agree. So that might be a utility if the patient's very obese or different body habitus factors to consider the biomarker testing and things like that.
Thank you.
Thank you.